These muscles, okay, trapezius. These are the 5 muscles that act on the scapula. Trapezius and levator, of course, are also neck muscles, but they're more scapula. It's easier to remember them with the scapula. So trapezius, of course, originates on the occiput, okay? Trapezius originates on the occiput, runs all the way down through T12, runs through the whole thoracic spine, attaches to the ligamentum nuchae, okay? So the ligamentum nuchae is a ligament that comes out. It extends the spinous processes of the spine, okay? Extends the spinous processes of the spine, all right? And it creates like a connective tissue for muscles to attach to. Fun point, test question is not on here, that does come up. If you wanted to feel the ligament of nuchae, you want to feel the contrast and tension, you would have your person, you would put your fingers on it, have them flex and extend, and you'll feel the ligamentum nuchae. Test point. Flexion and extension will allow you to feel the tension of the ligamentum nuchae, okay? So trapezius attaches to the occiput, ligamentum nuchae, and the transverse process, spinous processes through T12. Gotta fix that. Spinous processes through T12. Spinous processes through T12. It inserts at the same place that the deltoid originates. So it inserts on the lateral clavicle, the acromion, and the spine of scapula, okay? So lateral clavicle, acromion, and spine of scapula. I like to call it the hook, right? The hook, right around here. As you can see right there. Attaches to the hook. It's a neck muscle and a contralateral rotator, so double driller. It's on the back, so it's going to extend, one on each side, so it's going to side bend, and it's going to contralaterally rotate. It's going to rotate to the opposite side, right? For the scapula, the upper fibers, as you can see, it reaches down and grabs onto the scapula. It's going to elevate the scapula. The middle fibers are going to adduct the scapula, so it's going to pull the scapula together, okay? It's going to pull the scapula to the spine, adduct to the spine, add it to the spine, or retract. Be familiar with adduct and retract and abduct and protract, okay? Adduct or retract, abduct and protract, okay? And then the lower fibers, please don't forget this, are going to depress. So these lower fibers reach up, grab onto the scapula, and pull it down. Okay, so besides neck muscles, besides extend, side bend, and contralaterally rotate the neck, it acts on the scapula. So it elevates, adducts, and depresses the scapula. Okay, it also rotates, but we'll get there in just a second. Right, levator scapula inserts at the superior angle. So right here at the superior angle, starts on the transverse processes of the spine, inserts on the superior angle of the scapula. Okay. And it's a neck muscle, first and foremost. So it's going to extend, side bend, and ipso rotate. No contralateral rotation, regular schmegular. The right side is going to pull you to the right, left side is going to pull you to the left. But it's also going to elevate the scapula because it is the levator scapula. Right? Rhomboids originate on the spinous processes and go to the medial border of the scapula. Okay, make sure you know that. The rhomboids can be found between the scapula. They look like little Christmas trees. The fibers go down like a Christmas tree. So if the fibers go down like a Christmas tree, how are they going to pull on the scapula? They're going to pull them up and together, elevate and adduct. Okay, or retract. Elevate and adduct / retract the scapula. They're going to pull them up and towards the spine. Okay. On the other hand, we have our serratus anterior and pec minor. Okay. Green is our serratus anterior, our superhero muscles. Okay. Pec minor, right up in here, ribs 3 through 5 to the coracoid process. So again, they both attach to the ribs, so we can assume they help with breathing, but serratus anterior from the ribs to the medial border of the scapula, okay? Rhomboids attached to the medial border of the scapula. Serratus anterior comes from the front, passes in front of the scapula and attaches to the medial border on the anterior side. So the medial border is shared by rhomboids and serratus anterior. It's worth remembering that because then you'll recognize they're in a direct tug of war for the scapula, okay? Pec minor originates on the ribs and also reaches up and goes to the scapula. It attaches to the coracoid process along with biceps and the coracobrachialis, okay? 3 muscles attached to the coracoid process, and pec minor is one of them. So you must remember, pec minor attaches to the scapula. It's on the front, but it catches that creepy finger that comes through to the front. Yeah. Okay. Together, they work on the scapula, and they are in a direct tug of war with the rhomboids. If the rhomboids elevate and adduct, these bad boys are doing the exact opposite. They're like, no, we want to go this way. They're going to depress and abduct, okay? Visualize like you're holding a baby. That serratus anterior comes up and back. It's going to pull the scapula forward and down. It's going to abduct and depress the scapula, whereas rhomboids want to adduct and elevate. So if you remember one of these, you know the other one because they do the exact opposite, okay? They both, the serratus anterior and rhomboids both attach to the medial border of the scapula. Rhomboids wants to elevate and adduct, whereas serratus anterior wants to depress and abduct, and it has help from its little helper, pec minor, okay? Direct tug of war. Remember one, you'll know the other. All right. Thoracic outlet syndrome for pec minor. Back to thoracic outlet syndrome. That brachial plexus comes out from the middle and anterior scalenes underneath the clavicle behind pec minor, okay? So if you see that right there, imagine a big, thick bundle of nerves coming underneath that muscle. If that muscle gets tight, or if you spend a lot of time doing this, electricians and whatnot, it compresses on that. It can compress on the nerve, or it could compress on the blood vessels, but on the nerve is more common, okay? And MBLEX is usually going to talk about numbness and tingling down the whole arm and the whole hand because it's up here where the nerve starts. So it's more widespread than like carpal tunnel, which is just going to be these fingers. All the hand is going to be numbness and tingling, paresthesia, okay? Brachial plexus compression, thoracic outlet syndrome, pec minor, scalenes. Is there anything else here? Yes. Okay, here we go. So all 5 of these, this is good enough. This is good enough. If you remember this, you're good. But extra little point, if you get back around to it, they all rotate the scapula. And this is where my driller came in. If you remember that these two, the trapezius and serratus anterior, upward rotate, all the rest of them downward rotate. That is bonus cookie points if you could remember that, but don't worry if you don't. Okay? Trapezius and serratus anterior both upward rotate. Pec minor, rhomboids, and levator downward rotate. That's why it's gray, but it's there. Because kudos if you can remember it. It took me till like the 4th class to finally say, okay, I'm going to remember this. I'm going to make the effort to remember it. I've taught it 4 times now. I should remember this at some point. All right. So that's the scapula. Moving into the shoulder. Okay, the shoulder. That was the scapula. Scapula, by the way, being scapulothoracic. Remember, that's a false joint. It's not an actual joint. That's just where the scapula glides along the thoracic cage, right? So we call that the scapulothoracic joint. This is why flexion of the shoulder, all that stuff, when we say shoulder, they could be talking about the scapula or the glenohumeral, which is why on mines, you will see GH for glenohumeral. Okay, and scapula for scapula, but all of it is considered the shoulder. So starting with deltoid, trusty old deltoid there. All right, originates at the same place where the trapezius inserts. The lateral clavicle acromion spine of scapula, right around the hook. Okay. right? And it inserts on its own insertion the deltoid tuberosity, okay? It's not even on there. But it has anterior fibers, posterior fibers, and middle fibers. Commit either the hip or the deltoid to memory and you'll know the other, okay? We usually understand deltoid a little better. So the anterior fibers, because remember, muscles pull. So the front fibers are going to do the flexion and medial rotation because it has to pull into flexion, pull into medial rotation. So the anterior fibers flex and medial rotate. The posterior fibers extend and lateral rotate, okay? All of them abduct. The whole deltoid abducts the shoulder, okay? And then, of course, grayed out horizontal adduction and horizontal abduction are also there. So horizontal adduction, horizontal abduction. In the front, it's going to pull into horizontal adduction, and the back is going to pull into horizontal abduction, okay? Latissimus dorsi also acts on the glenohumeral. And we know that the teres are flunkies. Teres major is a little helper. It's a flunky for the bigger latissimus dorsi. Teres minor is a flunky for the smaller infraspinatus, okay, right over here. Teres minor, teres major, okay? And if you look, they both originate on the lateral border, which you'll see right there, okay? Teres major is down lower with his big brother, latissimus dorsi, and teres minor is up a little higher with his big brother, infraspinatus. Okay, but they both live on the lateral border. Latissimus dorsi originates on the thoracolumbar fascia down here. Okay, both of them insert at the bicipital groove. That is a bony landmark or attachment site worth remembering. Bicipital groove, or intertubercular groove is the better name. That's the newer name, but MBLEX still says bicipital. Okay, so right here, we have our lesser tubercle, greater tubercle. I don't know if you guys can see that. Right here, the bicipital groove. Okay, so latissimus and teres major both attached to the bicipital groove. So these muscles reach from the back and attach right here to the front of the arms, right? And we call these the arresting muscles. Okay, why? Because if you're going to get arrested, these muscles are going to put you in the right position. So from anatomical position, you're getting arrested. You got to extend the shoulders. You have to adduct the shoulders. Then you have to medially rotate to turn your hand around and catch these cuffs. Okay? So extend, adduct, and medially rotate the arresting muscles. Okay? Latissimus dorsi and teres major extend, medially rotate, adduct. They are the arresting muscles. Okay. Then we have our rotator cuff muscles. My goodness, we love the rotator cuff muscles, don't we? Said no one ever. Okay. Remember sit. So supraspinatus, infraspinatus, teres minor, subscapularis. You remember the first S is supra because it's super and above, and the last S is sub in the basement, okay? So supraspinatus, infraspinatus, teres minor, subscapularis. Remember that rhythm. Supraspinatus, infraspinatus, teres minor, subscapularis. Sits, okay? These three all start in the fossa. So supraspinous fossa, infraspinous fossa, subscapular fossa. We know subscapular is in the front, okay? So they all originate on their own fossas, and teres minor originates on the lateral border with his big brother, with his little friend, teres major, right? What just popped up? My picture over here. All three of the first sit, the SIT, it's out that way. It's out that way. The SIT inserts on the greater tubercle. Okay, that is a test point. All three, the first three, the sits insert on the greater tubercle. I don't know if you remember this, but if you kind of put your fingers like that you have SIT on the back, on the top, and then subscapularis in the front on the lesser tubercle. Okay, so the sit all insert on the greater tubercle, the subscapularis inserts on the lesser tubercle in the front by itself because it's the only one on the front. Okay, it's the only one on the front. And for the actions, if you remember them in this order, you also remember the actions because we're going to throw the ball. Okay, first we're going to pick up the ball. So we're going to abduct. Okay, supraspinatus abducts to pick up the ball. Okay, abduction. Then these two work together because Terry's is always a flunky. They're going to wind it up. So they're going to laterally rotate. Okay, remember, lateral rotation is external rotation. So in this plane, from anatomical, it looks like this. But even as we bring our arm up, this is still external rotation, external rotation, external rotation, right? So we abduct it, we externally rotate it to wind up the ball. What's the last step? Got to throw the ball, medial rotation. Okay, so abduction, lateral rotation to wind it up. That's Terry's, that's infraspinatus and Terry's, and medial rotation to launch it for subscapularis because it's on the front. So it medially rotates. The other two are on the back. They laterally rotate. Remember that pulling action. Infraspinatus and Terry's minor on the back, so they laterally rotate. Subscapularis is on the front, so it medially rotates. Okay? And supraspinatus test point, it can be impinged. So supraspinatus passes from the supraspinous process underneath the acromion, and it can get impinged there. So when you go to abduct your shoulder, it passes underneath this big bony structure right here. So it can get impinged, right? Underneath the acromion process, right at the top of your shoulder. Very painful, okay? And then, of course, subscapularis is usually associated with adhesive capsulitis, okay? Medial rotation becomes very difficult and becomes stuck. Subscapularis. Right? Moving on. I don't have time to stop for all of the questions. I will throw them on at the end, so those who have to get off, they don't miss as much, but this is being recorded. It will be all on there, so you can like catch whatever you don't have time to stay for. All right, so moving on with the shoulder. So that was most of the shoulders, right? These are the 5 brachium muscles and pec major. So pec major and the 5 brachium muscles. So pec major, of course, is the last muscle that pretty much solely acts on the shoulder, the glenohumeral. Pectoralis major starts on the clavicle, the sternum, and the ribs, inserts on the bicipital groove. 3 muscles insert on the bicipital groove. Teres major, latissimus dorsi, pectoralis major, all insert right here on the front of the shoulder. They pass through the axillary to the bicipital groove, okay? So pectoralis major is on the front. It's going to flex. It's going to adduct because it's down here. It adducts. It pulls into adduction. And it's on the front, so it medially rotates. It's pulling the front of that humerus towards itself. So adduction, flexion, medial rotation. Grayed out is going to be horizontal adduction, okay? It does horizontally adduct and also extend. This is gray, but when you do a pull-up, I'm pretty sure you're fully aware, pecs are working. Even though we think of extension as back here, this here is also extension. So from this position, pec major reaches up and extends. From up here, extension. Again, that's gray because I have yet to see that particular point come up on any, nobody has ever come back and said that they remember that question, okay? But you can't recall it if you've never heard it, okay? So yes, pec major also does extend. As evidence, when you go to do a pull-up, you got to recruit a lot of muscles because a pull-up is serious business, right? When you do this action and you're pulling up all your body weight, your pecs are involved, okay? So, but that's why it's gray. Then you have coracobrachialis, our 5 brachium muscles. Coracobrachialis, biceps brachii, triceps brachii, brachialis, brachioradialis, okay? So coracobrachialis, There they go. Coracobrachialis starts on the coracoid process and goes to the medial humerus. It tells you right in the name, coracoid brachium, coracobrachialis, okay? And it flexes and adducts the shoulder. Flex and adduct the shoulder. Flex and adduct the shoulder. It's going to pull into adduction, okay? It's below and on the inside, so it can pull into adduction. Biceps brachii originates on the supraglenoid tubercle and the coracoid process. The long head, it goes at the supraglenoid tubercle, the short head at the coracoid process, okay? So here's our supraglenoid tubercle right there at the top of the glenoid cavity. The long head passes through the intertubercular or bicipital groove, okay? The short head starts right on the coracoid process here and comes down, all right? As you can see in the picture there, there's the short head, there's the long head passing through the bicipital groove, okay? They insert on the radial tuberosity, all right? So that's this point right here on the radius. I don't know if you can see that, but the radial tuberosity right there, okay? The tendon for the biceps can be felt, can be palpated in the cubital space. Please remember that. The tendon for the biceps brachii can be palpated in the cubital space. Feel it. Take your hand, supinate, you feel that biceps tendon nice and tight right in there, okay? It flexes the shoulder and the elbow, full flexion. So it crosses the shoulder and the elbow joint, so it has to do both. It's going to flex the shoulder and flex the elbow. But then don't forget, it is the prime supinator, okay? It does supinate. If you can't remember whether it supinates or pronates, put your finger right there. They can't take that away from you. Put your finger in here and supinate and pronate. When do you feel it nice and tight? When you supinate, okay? It is prone to tendinitis at the bicipital groove. So sometimes we feel pain right up here in the front of our shoulder. And a lot of times that's the biceps tendon being irritated and inflamed as it passes through its sheath and through the bicipital groove. We feel the pain here, but that's very much bicep aggravation, okay? So tendinosis at the origin, near the origin, as it passes through the bicipital groove, okay? It's a test point. And then moving on, brachium, very straightforward. We love this muscle, super easy. Anterior brachium to the coronoid process, flexes the elbow. That's it. Usually you just want to know that it flexes the elbow and it's deep to the biceps. That's how that question usually comes up, okay? Deep to the biceps, flexes the elbow. Triceps brachii is the only muscle of the posterior brachium. This is the brachium. This is the antebrachium. The only muscle on the back of the arm is the triceps. And coneus is on the back of the elbow, okay? So it starts on the infraglenoid tubercle. So right in here, below the glenoid cavity on the scapula, and it starts on the shaft of the humerus, and it inserts at the olecranon process. Do remember that, the olecranon process, okay? So here we go, right here, the actual elbow, like the actual elbow bone, olecranon process, all right? You must palpate through the triceps tendon to access the olecranon fossa, okay? So if this is the olecranon process on the ulna, there is a fossa on the humerus that receives it, okay? Can you see that? There's a divot right here that receives that olecranon process, okay? And the triceps tendon passes right over that to get to the olecranon process. So if you were to have a question that said, what muscle must you palpate through to access the olecranon fossa, you know the triceps passes right over that, and you got to go through that tendon to get to that olecranon fossa. Okay. Actions, of course, extends. It's the opposite of the biceps. Biceps full flexion, triceps extend the shoulder, extend the elbow. Okay, extend the shoulder, extend the elbow. You can go, okay? If you need to go, you can go. Don't worry. All right, and then Anconeus is the little helper right there with triceps, extends the elbow. Anconeus, the cone on the elbow. That's about what you need to know. Don't worry too much about that one. Brachioradialis. Brachioradialis right in here. If you want to see brachioradialis, make a fist, resist it, and you will see that brachioradialis tendon pop up, or like underneath your desk, like press really hard. You'll see that tendon, you'll see the muscle attached to the lateral side, okay? Specifically, the lateral supracondylar ridge. I hope and pray that doesn't come up, but I've been humbled before, and it's depressing. But it starts up here on the lateral humerus, okay? Lateral elbow up here. Lateral supracondylar ridge to the radial styloid process. So it does not cross the wrist. It has nothing to do with the hand. It stops right here at the radial styloid process. Okay, the hand is just dangling there. All right, and it's going to flex the elbow and supinate and pronate. I always say, think about the radio, okay? Turning the dial on your radio, supination, pronation. Okay, so brachioradialis, supination, pronation, because you're turning the dial on your radio. Think about supination, pronation against resistance, like tightening or loosening a screw with a screwdriver. It's going to require a little bit of That's what brachioradialis does. Also, it flexes more from a neutral position. Here's anatomic. That's going to be brachialis, right? From a neutral position, like thumbs forward, hammer curls, brachioradialis. Okay. And then forearm and hand muscles. Forearm and hand muscles, keep it as simple as possible. The more you remember, the better. If you can remember that the flexors and extensors start on the medial epicondyle and the lateral epicondyle, you're doing very good. Flexors obviously flex. It's in the name. Extensors extend. Simple enough, right? Flexors are on the medial epicondyle, medial epicondylitis, tendonitis, medial elbow, golfer's elbow, okay? Your client is experiencing pain on the medial elbow. What muscles might be impacted? What action might be challenging? Flexion, flexors, okay? Your client has pain on the lateral elbow. I'll just point to the lateral. Your has pain on the lateral elbow, lateral epicondylitis, tendonitis on the lateral elbow, tennis elbow, okay? Extensors are going to be the target, and it's going to be more difficult to extend, okay? Then we have all these terminology. I still don't think it's super important, but I did get a question that wanted you to know that carpi meant wrist, okay? Like which one of these muscles flexes the wrist. So as far as these, it's too much trouble to try to memorize every single muscle. If you have an idea of the terminology, that's all you need to know, okay? So carpals means wrist. It controls the carpals. It controls the wrist. So when you have flexor carpi radialis, that muscle starts on the medial epicondyle because it is a flexor, and it's going to control the wrist because it is a carpi, and it's going to insert somewhere just past the wrist because it controls the wrist, okay? Indicus means this finger, index, indicate, indicus. Digitorum means fingers 2 through 5, not the thumb, 2 through 5. So extensor digitorum, it's safe to assume they start on the lateral epicondyle because they are extensors. They run all the way to the fingers because they act on the fingers. They also are going to extend the wrist because they cross the wrist as well, okay? Digiti minimi, mini-me. That's these muscles right in here that control the pinky. And then what just popped up? Okay, radialis means it inserts on the radial side, and it also radial deviates, okay? It inserts is what's going to be a carpi, right? So flexor carpi radialis starts on the medial epicondyle. It inserts just past the carpals on the radial side. It's going to flex and radial deviate. And remember, radial deviate also means abduct the wrist. Ulnar deviate means adduct the wrist. And ulnaris inserts on the ulnar side. So flexor carpi ulnaris, extensor carpi ulnaris, you start to see how each muscle tells you exactly what it does, where it attaches, and what it controls. Keep it simple. Do not get lost in that sauce. It's not worth the effort. Just know your terminology, and it should take you far enough to be able to give an educated guess on that question. Okay? Then, of course, you have pollicis. Pollicis insert at the thumb. There's 8 muscles that control the thumb, if you remember that. This is worth remembering. The hypothenar and thenar eminences, okay? Thenar eminence is the short pollicis muscles. Pollicis brevis, adductor pollicis, opponens pollicis, all that good stuff. Digiti minimi is the fatty pad or the muscle pad, the fleshy pad on the lateral side, okay, on the pinky side. What that's going to look like is carpal tunnel. The median nerve passes between the thenar eminences alongside the flexor tendons. That is saying a lot, but I promise you, you'll want to know that, okay? The median nerve passes between the thenar eminences. This is the carpal tunnel. The carpal tunnel is between the thenar eminences. The median nerve passes on the flexor side, okay? So if you were to get a question that said, what muscles do you want to target when you're dealing with carpal tunnel, it's the flexors that are getting inflamed and tight and squeezing out the median nerve, okay? And that structure passes between the thenar eminences. That you want to know. Also, de Quervain's tenosynovitis, snuff box. If you guys remember, we have an anatomical, literal snuff box right here. That's where the long pollicis muscles pass through. This is where you get de Quervain's tenosynovitis. Okay, mommy thumb, if you will. Mothers get this a lot dealing with babies and whatnot. Okay, so 2 points right there. You definitely want to remember. While we're here, the supinator, associate that with the extensors. It's deep to the extensors on the lateral elbow. Okay, whereas pronator is on the medial epicondyle. Again, muscles pull. So if we look at this, right? Supination, to pull into supination, you got to come from the lateral side and pull the hand up. For pronation, you got to come from the medial side and pull the hand down, okay? So the supinator is deep to the extensors, and it is a antagonist to the biceps. That's how that question could come up, okay? Supinator is deep to the extensors, and it is a antagonist to, synergist to biceps. It is a synergist to biceps. Pronator teres is a antagonist to biceps because pronator pronates, biceps supinates. Supinator is a synergist to the biceps, synergist to the biceps. Ooh, it's been a long day. All right. So that's the hands. Moving into the legs and thigh. Are y'all still with me? Sorry. You got to drop off, do what you got to do. I'm still going to be recording. I'm still going to post it some kind of way. All right. So let's start with iliopsoas because we've done all the upper body stuff. We've done the abdominals. We've done the back. Get into the legs. Almost done. So iliopsoas, of course, iliacus and psoas major. Iliacus starts on the iliac fossa. Iliac fossa right in here. You can see that big red spot, okay? Psoas major starts on the lumbar vertebrae and transverse processes, okay? So these muscles come down through here, go behind the inguinal ligament. I drew it in right there. Behind the inguinal ligament. And they both insert on the lesser trochanter. So they reach around to the lesser trochanter in the back. They come down and reach around to the back of the thigh at the lesser trochanter. So imagine that. I've come down here. Now I'm going to flex the hip and laterally rotate the hip because it's reaching from the back and pulling towards it. So it's going to laterally rotate the hip, okay? Creepy hands, down behind the thigh, flex and open. So laterally rotate, okay? I'm sorry, but it helps. Okay, flex the hip, laterally rotate the hip, okay, because it also attaches up here. If the legs are stable, then it's going to flex the trunk towards the thighs, right? Because it has a reverse action. So much so, in fact, when you lay down and you do a crunch, why do you have to bend your knees? Because if you don't, your psoas is going to be doing your sit-up. When you flex your knees, you inactivate the psoas, and now your abdominals are doing the crunch. Okay? So, iliopsoas flexes the hip and laterally rotates the hip. But it also, if your legs are still and now you're moving your upper body, it's going to flex the trunk and, of course, anterior tilt, because nosy people lean anteriorly. Here's your P, the psoas, okay? The iliopsoas anteriorly tilt. It's going to pull the pelvis towards itself. It's the hip flexor, okay? And then, of course, laterally flex the spine because there's one on each side for psoas. I don't feel like that really comes up, but it does laterally flex as well, okay? Spastic hypertonicity as a result of scoliosis. If somebody has scoliosis, okay, that means they have kind of a twisted back. It could give you spastic hypertonicity in the psoas muscle, okay? Just remember that, trust me. Okay, then we have our groups. I love the legs because they are in nice, neat groups, although they get kind of messy once you break the muscles down. So let's just do it. All right, so of course our quads include the vastus muscles, okay, the vasti, vastus intermedius, vastus lateralis, vastus medialis, vastus intermedius is the deepest, okay? Vastus lateralis is the only muscle of the lateral thigh. It's the sole muscle that makes up the lateral thigh. IT band crosses over it, but that's not a muscle, is it? Vastus lateralis is the sole muscle of the lateral thigh. It's right next to biceps femoris, the hamstrings, okay? It's adjacent to the biceps femoris. And vastus medialis is the medial one, right? Rectus femoris is the only one that actually crosses the hip, okay? So it actually crosses the hip up here. So all of these originate in different places, and they're all grayed out because I really don't think it'll come up. But rectus femoris does originate at the anterior inferior iliac spine. That one might be worth remembering, okay? So rectus femoris originates up here at the, remember this is the anterior superior, anterior inferior iliac spine. Because rectus femoris specifically crosses the hip, we talk about the quads as a group flexing the hip, but specifically it is the rectus femoris that crosses the hip, okay? But we still discuss them as a group in general. Imblex does as well, all right? So all of them insert on the same place, the tibial tuberosity via the patellar tendon or ligament. All right, so here we go. Here is the patella, okay? Patella. The patella is embedded in the quadriceps tendon. Up here is the tendon because it connects the muscle to the bone. Down here, it's a ligament. So you can hear either one. Tibial tendon, tibial ligament, it doesn't matter. It means the same thing. And it inserts on the landmark of the tibial tuberosity, right in the front. Okay, the tibial tuberosity is what you pay attention to when you observe medial and lateral rotation of the knee. Tibial tuberosity. Also, if someone who has a history of Osgood-Schlatter, that sounds familiar. You have a young athlete that has pain in the knee around the tibial tuberosity, they probably have Osgood-Schlatter because their growth is not keeping up. I think the connective tissue or the muscle, one of them is not keeping up, and they get a lot of pain right here, a lot of jumping, a lot of stress on their knees. An adult who has a history of Osgood-Schlatter will have a noticeable lump at their tibial tuberosity, okay? So, and of course, the quadriceps can directly impact the patellar position. That is a test point, okay? They can pull on the patella and cause it to deviate from its proper space, okay? So then They all extend the knee. That's the main thing that the quadriceps do. They extend the knee, okay? All that tissue, all that muscle, all that thigh is important because it extends the knee. Why do we need, and here's the thing about the legs, where it gets tricky. Why do we need so much muscle just to do this? Because that's not what we're doing. Most of the time, our feet are planted, so extension of the knee looks like this. You need to be able to stand up, okay? We often think of the arms and stuff as we are stable and we're moving the arm. When you get to the legs, we have so much power in our legs because 9 times out of 10, the legs are stable and we're moving our entire body, okay? That's why you need so much muscle just to extend the knee, because you have to stand up, right? So it extends the knee, and then of course, rectus femoris passes the hip. So that means the quads also flex the hip and anterior tilt the pelvis, okay? Observe, if the quads get tight, they reach up and grab onto that pelvis and pull down into an anterior tilt. So there's your other cue of the P's and Q's, right? One second, so sorry. Okay, so if you need to log off, I totally understand. I'm going to keep recording and I will post it. So anterior tilt for the quads. Okay. Whew. Anterior tilt the pelvis. There we go. So now we get into our hamstrings. Hamstrings, of course, are direct and complete opposites of the quads. Everything about them is opposite. Okay. First of all, we have biceps femoris and then our semis, semitendinosus, semimembranosus, in that order. Biceps femoris is lateral, then semitendinosus, and then the deepest and most medial is semimembranosus. Okay. They're even opposites in structure, where all the quads start in different places but insert in one place. All the hamstrings originate in one place and insert in different places. Okay. So then we know that they all originate at the ischial tuberosity. If you remember nothing else, you must remember that. The hamstrings all originate at the ischial tuberosity. Your client has pain at the ischial tuberosity. What muscle might be impacted? Okay. What action might be more challenging? Anything that the hamstrings do. Okay. The biceps femoris inserts on the fibular head. I would make an effort to remember that. Okay, so they come down behind the knee. That's the thick tendon on the right side that attaches to the head of the fibula. So right here, comes down, attaches on the lateral side to the head of the fibula. Whereas semitendinosus, driller, pes and serine, it attaches to the medial proximal tibia at the pes and serenus tendon. Okay, and then we have semimembranosus, which comes down to the medial condyle of the knee, okay? All of the hamstrings extend the hip, flex the knee, and posterior tilt. Exact opposites of quads. If you remember one, you know the other. The quads flex the hip, the hamstrings extend the hip. The quads extend the knee, the hamstrings flex the knee. The quads anterior tilt, the hamstrings posterior tilt. Complete and utter enemies for life. Okay. And then, of course, there are some secondary actions that we really don't care much about. It's very useful in practical application if you do therapeutic work, but we don't care about it for MBLEX. The biceps femoris also laterally rotates the hip and knee, and the semis medially rotate the hip and knee. Pes and serine is a clue to that, right? So please, we got too much to worry about. Sartorius, trusty sartorius. Longest muscle in the body, okay? It is medial to the quads. It is lateral to the femoral triangle. Please remember that. It is lateral to the femoral triangle. Remember, the femoral triangle is an endangerment site because we have the femoral artery, the femoral nerve, femoral vein, I think, as well, and then lymph nodes, all in this area, okay? It is lateral to the femoral triangle. Starts on the anterior superior iliac spine. So here's rectus femoris at the anterior inferior. Here's sartorius at the anterior superior iliac spine, okay? Comes down, wraps around the thigh, goes again to the pes anserine. So right off the bat, we already knowing it flexes the knee and medially rotates the knee. Flex the knee, medially rotates the knee. Flex the knee, medially rotates the knee. But what does it do for the hip? It helps you sit crisscross applesauce, okay? So if you want to sit on the carpet, on your color, crisscross applesauce, you need to flex your hip, abduct your hip, laterally rotate your hip, flex your knee, medially rotate your knee. And now you're sitting crisscross applesauce, okay? Flex your hip, abduct your hip, laterally rotate your hip, flex your knee, medially rotate your knee. And now you're sitting crisscross applesauce on the floor, okay? Sartorius. It's called sartorius because it's called the tailor's muscle. And that's apparently how tailors used to sit when they were sewing. I think crisscross applesauce is a little easier to remember, okay? Or I think lotus or something if you're into yoga. So, right? Moving along, our adductors, which we absolutely hate. I hate the adductors, right? Just know what muscles are in the adductors: pectineus, adductor brevis, adductor longus, adductor magnus, and gracilis, okay? Those are the adductors, 5 adductor muscles, 3 adductor, pectineus, and gracilis. So adductor brevis, adductor longus, adductor magnus, and gracilis, okay? Because I'm adding origins and insertions, I have them split up, but for the most part, I wouldn't even bother. They all start around the base of the pubis. They have very annoying and distinct origins going all the way around here. For the most part, they create a curtain of tissue that comes all the way around the base of the pelvis, starting at the superior ramus of the pubis, pubic tubercle, the inferior pubic ramus, the ischial ramus, yada, yada, yada. We don't care, all right? They start all the way around here, okay? Adductor magnus does come back to the ischial tuberosity because it is the 4th hamstring. So it has the same origin. It comes all the way back to here. It starts all through here, okay? But they also insert on different places. Gracilis inserts on the pes anserine, that's the driller. So we know that's the one that flexes the knee, okay? And then we don't even care about the rest, okay? But here's the thing about the adductors. They have complex actions. If you can remember that they all adduct and medially rotate the hip, you will be fine. They all adduct and medially rotate the hip. As a group, all of them adduct and medially rotate the hip, okay? Now, if you care to remember, it's in gray. Everything except gracilis also flexes the hip. Gracilis is right down the middle, so it doesn't have the pull to be able to flex, but pectineus and all the adductors also flex the hip, okay? Gracilis has a side hustle on the weekend with the pes anserine muscle, so it also flexes the knee and medially rotates the knee. And also in gray, adductor magnus is the 4th hamstring, so it also extends the hip because it is that big. It runs from the front to the back, so it flexes and extends, okay? But for imblex, they adduct and medially rotate the hip. If you remember that, you're doing great, okay? Okay, so our deep 6 lateral rotators, again, I don't think that these even come up as separate muscles. I'm really not tripping over the origins and insertions. Don't even care about them. But they all originate around the ischium, okay? Keep it at that, except for piriformis. Piriformis originates on the sacrum. That one you might want to remember. So piriformis, here's a muscle, okay? Originates on the anterior sacrum and passes through the greater sciatic notch, okay, and inserts on the greater trochanter. All of these muscles, in fact, insert somewhere around the greater trochanter. So the deep 6 lateral rotators are deep in the hip. They start on the ischium. They insert on the greater trochanter. Piriformis starts on the sacrum, okay? And all of them do what? They're the deep 6 lateral rotators. They lateral rotate. That's it. They lateral rotate. Okay, but piriformis also abducts a flexed hip. Okay, it abducts a flexed hip. Abducts the flexed hip. That muscle comes through here, attaches to this part right here. So once the hip is flexed, it has a clear trajectory to abduct the hip. This is why when we want to stretch piriformis, we will flex the hip and then push it across the body and adduct it across the body. That's how you stretch the piriformis, okay? And the piriformis can cramp down on the sciatic nerve. Piriformis syndrome, a really tight piriformis is a pain in the butt, quite literally, okay? Then we got to put our elbow in the butt to press on it and try to, okay? And there you have your sciatic nerve that I drew in, okay? Because piriformis is superficial to sciatic nerve. So if it gets tight, it can press down on it, okay? And here's obturators, okay? So obturators, gemelli, quadratus femoris, piriformis are our deep six lateral rotators. And of course, our hip muscles, okay? And in my world, in my class, tensor fasciae lata is a part of the glutes, as it should be, okay? Tensor fasciae lata and gluteus minimus are complete synergists. They do the exact same thing. They're kind of in the same place. Gluteus medius and then gluteus maximus. So tensor fasciae lata originates on the iliac crest, posterior to the ASIS. It inserts on the iliotibial tract, okay? And gluteus minimus and gluteus medius both originate on the gluteal surface, basically just the outside of the hip, okay? And they both insert, these two insert on the greater trochanter. The minimus and medius both insert on the greater trochanter. That was a test point, that the medius inserts on the greater trochanter, okay? And then, of course, gluteus maximus inserts on the IT tract. So TFL not only does the exact same actions as glute minimus, it also has the same insertion as glute maximus. So in my class, TFL is right there with the glutes. TFL and glute minimus are in the front. Medius is in the middle. It does everything. And gluteus maximus is in the back. Okay. So iliotibial band syndrome for the iliotibial tract, if you have pain on the lateral condyle of the knee, so if you have pain on the outside of the knee, that could be an indication of iliotibial band syndrome. Remember that. Okay, so all of them abduct the hip because these are the deltoid of the hip. They all abduct the hip. That's the main thing that the hip muscles do, that the gluteus muscles do, abduct the hip. Okay, but then those front fibers act like the anterior deltoid. They flex and medially rotate. Okay, they're going to flex and medially rotate the hip. Whereas the the maximus is going to extend and laterally rotate because it functions like the posterior fibers of the deltoid. Extend and laterally rotate because it's on the back. It's going to pull into extension and lateral rotation, okay? And then medius is the deltoid of the hip because it has anterior and posterior fibers and it does all of it, okay? So tensor fasciae lata, glute minimus, flex and medially rotate. Glute maximus is in the back. It extends and laterally rotates. Glute medius is in the middle. It does it all. Flex and extend. Medial rotate and lateral rotate. And then all of them abduct. Okay? And that's your glute muscles. What just changed? Okay. Finally.